Dr. Claytor here to talk about facelift surgery. Just got out of the operating room. This is my headgear and my headlight so that I can see what's going on. Many patients want to know, how can I go from being aged to being youthful? Same patient before and after surgery. What's going on is we're aging is multifactorial. We are losing volume in our face because the fat is breaking down. We are losing structure in our face through osteoporosis. The bones are actually involuting and we're getting facial descent. The skin is losing its elasticity. So all these different elements need to be replaced if you're going to go from aged to youthful. First thing we need to understand is, how do we approach this? And what are the different elements that we're going to work on? The first thing is, where are we going to make our incisions? The incisions optimally are hidden so that you cannot see them. We'll hide them along the hairline here. We'll hide them along the ear line, in front of the ear if it's a man, back in front of the tragus if it's a woman. You don't want to pull hair-bearing tissue up onto this tragus, which is this part of the ear if it's a man. For women, you would like to hide it as much as possible. Sneak it down underneath the ear lobule and then back up behind the ear, again hidden. And then a little bit of an incision back into here, again hidden when you're wearing your hair down, or for a man if they wear their hair just over the edge of it. Very, very well concealed. A lot of times I like to extend the incision up into here, and that allows me to work on the vector, because as we're aging, everything is coming down. So that doesn't mean we pull this way. That's the windswept look. It's not really an aesthetic look, and it's very much a dead giveaway that somebody has had a procedure. The patients who are coming to see me more often than not say, please, 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 I want to look more refreshed and rejuvenated, but it's not something that I want everyone to be able to notice. So we want to correct, not to change. We want to correct the vector vertically. We want to go up this direction with what has gone down. And so that's why I like to make the incision up into the hairline. This is super well hidden. You can't see this at all. But by lifting this area, it gives me the ability to lift and put the vector sutures upwards as you're anchoring and doing the lifting. So here we are. What is it that is a facelift? It's not just pulling on the skin. That will relapse very quickly. That's what was done 50 some years ago. These patients would relapse very quickly. You need to address the superstructure underneath the skin, and it's called the SMAS. Superficial Musculoaponeurotic System, and it's basically the framework that the skin sits on. Underneath that are the muscles of the face. Underneath that is the bone of the face. Many times patients will come in and say, Doctor, I hear about this deep plane facelift. I don't really understand it, but I feel that it has been explained that it is the most superior technique. I would agree. A deep plane facelift is different than a SMAS plication in a very, very simple way. Think about it, that the skin comes up here, and if you lifted up the skin, now you're looking at the SMAS. If you lifted up the SMAS, now you're looking down at the muscles, and you're going a little deeper, you're looking at the bone. A SMAS plication is lifting up the skin and then plicating together the SMAS. The problem with this, or what I think represents a shortcoming of that procedure, is that you need to lift a fair amount of the skin up to get exposure to the SMAS so that you can plicate it together and lift that area. The problem with doing that is that you are delaminating that entire layer of skin. So you are interrupting the blood flow to it. You are interrupting the nerves to it. You are interrupting basically its continuity with the patient's face. A deep plane means that you're really only dissecting a little bit of the skin up, and then you're going down under the SMAS. The SMAS carries a lot of blood vessels, carries a lot of nerves, and so we call this in plastic surgery a composite lift, because you're lifting two things. You're lifting the SMAS and the skin. So when you're lifting the two of them together, it means it's a composite lift. So we're diving down under the SMAS along here. When you go down underneath, what are you going to come across? You're going to come across the muscles. What are connected to the muscles are nerves. This is what creates a level of anxiety for individuals when they're switching from doing a SMAS plication to a deep plane facelift. And it's a very good reason to look for a surgeon if they're going to be entertaining a deep plane facelift, somebody that has a true understanding of the nerves and understanding of the anatomy so that they know where they are and they can address them with deliberate care. So when you go under the SMAS, as in a deep plane facelift, you can go all the way out here and release the all-important retaining ligaments. If you take your face and move like this, there's a certain point at which it stops and you can't lift any further. And that is because there are certain retaining ligaments all throughout the face, and they have all fancy names, but I'm going to spare you all these fancy names to just point out that there are retaining ligaments. You can't get at them if you don't go under the SMAS. Again, another one of the very key elements in differentiation between a SMAS plication and a deep plane facelift, where we lift up the SMAS and you release the retaining ligaments that are going from skin through the SMAS down to the bone. So these retaining ligaments prevent the cheek re-elevation that many people are looking for. And so if you go in and we're now underneath here and you release these retaining ligaments, you are now able to take this tissue and re-elevate it in that superior orientation. So here's same patient before and after, and you can see how it improves her neckline. I don't have a 3/4 view here, but I'll show that in another video where you can see that malar mound go up and create that beautiful curved cheek view. But the entire point of what I'm getting at here is that by going down under the SMAS, you can release the retaining ligaments and reposition the cheek up into a more youthful and aesthetic position, and at the same time create that beautiful neck and jawline as well as that excellent angle of the mandible. When we close the patient's incisions, I do not use drains. I haven't used drains for years. I don't think that they're necessary. I have looked over my hundreds of patients, thousands of patients, and don't find that I'm seeing any more hematomas, which is the reason that people will use drains. And the reason for this is because I use tumescent fluid as the anesthetic. And so the tumescent fluid has a little bit of epinephrine in there, and it basically takes all of the blood vessels and causes them to scooch down, so you're not seeing any bleeding during surgery, number one. And then number two, a very genius surgeon from Brazil, Andre Arswald, came up with these hemostatic net sutures, which are tiny little stitches that we put across the neck, and again, close down that open space. Those stitches come out early, 48 to 72 hours, but what they do is they approximate that tissue and allow those tissues to close down and start adhering and basically close off any potential open space. No drains. Drains are just an annoyance, complicating, frustrating for patients, and they're completely unnecessary. Many great qualified surgeons do not use drains. I don't think that you need to go find somebody just because they don't use drains, but I think looking for somebody because they use drains is unnecessary. So again, all of these incisions are closed. Because these are up in the hairline, we use staples. I know it sounds a lot, but I promise you it's so much easier to put in and remove staples in the hairline. You can't see them anyway. These stitches are all placed using absorbable sutures that are buried underneath the skin, and they're very minimally noticeable. I've listened to many great surgeons talk at meetings and given these talks myself, and will share with the audience that this is a meticulous closure that is very necessary for an excellent result. To be meticulous in the closure here, because we want these scars to be as minimally noticeable as possible. So this can be a very lengthy and laborious part of the operation, but it's highly necessary. So at the end of the surgery, we put in a few of these hemostatic net sutures in the cheek and the neck area. I like to wrap patients up I've been doing this operation for years under what we call tumescent local anesthesia, so the patients are wide awake through the operation. At the end of the surgery, they sit up, we wrap them up, take them into the recovery room, and within 15 minutes or half an hour, they're with their loved one headed home. This is a absolutely amazing innovation in facial rejuvenation. The combination of the deep plane technique going underneath the SMAS, doing it under tumescent anesthesia, which is a very erudite way of saying awake anesthesia. Patients love it, it's super well tolerated, phenomenal results. I hope you found this helpful. Give me a call if you have any questions. Take care.